correct me if I can. All right, thank you. So what I'll do is go ahead and start and get some of the things out of the way, and then maybe call a recess for 5 minutes so we can get the very important stuff so everybody hears it. So welcome to the Human Services Committee. This is September the 13th, Tuesday at 5:30 p.m. by Zoom. https://townofbarnstable-us.zoom.us/j/81947919602, meeting ID 819-4791-9602. One Tap Mobile 877-853-5257, US toll free 888-475-4499, US toll free 833-548-0276, US toll free 833-548-0282, US toll free, meeting ID 819-4791-9602. Calling the meeting to order, Carlos Barbosa.
Yes, I'm here.
And I am also here, that's Cheryl Powell. We are waiting for two more that said they would be late, possibly three more. And I will try to acknowledge them as soon as they come in. Because we do not have the quorum of three, we can still go ahead and start, but I will try to hold off our guest speaker into giving those people time so that everyone. I see that Kim Crocker-Crowther has joined us. Hello, Kim. We're still waiting for two more as well. Kim, by the way, has one of the town council meetings was canceled, so she did not get the second read at the time that we thought it would be, but she was up on the next agenda for the town council. I'll also say here that there is a storm going on outside, so some of us may lose power, maybe not, but we have the numbers to call in if we need to go that way. I remember being in one meeting where we had a major storm and one person's house actually got hit, so it was kind of traumatic. So just to bring that to people's attention for the record. So update on committee membership. I've already mentioned about Kim. We have one other person who might be applying as well, which is excellent. To remind people about the conflict of interest training, it is necessary. Cynthia, are there any, I mean, obviously not to name names, but is there anyone on our committee who is not up to date on the conflict of interest?
Everybody on the Human Services Committee is up to date, with the exception of Ms. Crowther. As soon as she becomes a member, she'll have to complete it.
Okay, that's fine. I'd like to acknowledge Megan Mort. Thank you very much for joining us. Welcome. Megan is a full committee member. Oh, no, that's Kim. Sorry, Kim. It's Kim. Sorry, I've got a blurred screen. So it's Kim here.
I'm here.
Okay, sorry. I saw your name and I didn't realize the picture. Welcome. I was just saying how you have one more reading of the town council, and that's coming up. So we'll look forward to hopefully welcoming you on that.
Thank you.
Welcome. We're looking forward to that. And you and I have to, and everybody else has to work on getting one other position filled on this, all of us. Okay. I'm going to go into Cynthia, who was it that was coming in late aside from Kim? Was it Megan? Liz couldn't make it. It was Megan, was it not?
Scott Fitzgerald. Megan will not be able to make it. Her and Liz.
Okay, I knew it was Liz. Okay, so they won't be able to. So hopefully Scott will be able to.
And I'm not sure about Representative Zeros. He didn't decline the meeting, but he didn't say he wouldn't attend either. But something could have come up at the State House.
Okay, I understand. So Kevin, it's wonderful for you to offer to speak with us tonight. If you're okay, I'm going to ask you to go ahead and do your presentation, because the committee members will then need, in order to vote on it, to view the tape.
Okay, so just to be clear, you want me to present on the Gosnell overview and the changes that are kind of happening? Is that my understanding?
Well, Gosnell overview, but also you and I had, when I talked about, invited you, and delighted that you said yes. you were talking about teens and how that's one thing you don't have is like a teen center for addictions. And it's such a huge problem on the Cape. If you wouldn't mind touching base on that. But also the overview on that and addictions on the Cape and the need for help. Because mental health is one of the things we identified as being very important. We have to identify the key areas and then try to formulate a plan. Addictions, which you and I both know is often comorbid. Housing, which comes into a type of comorbidity. Those are some of the things that were highlighted. And I thought because it's and homelessness. So since it's such a huge issue on the Cape, if you could give us a overview, and we may have a couple people from the Cape Cod Healthcare joining as well, but we'll see them on the screen if they do.
Sure. So, and thank you for that, because honestly, I agree to show up to some things, and I put in the notes where you are from, but did not specify like what you were looking for. So I appreciate that. I just say yes, yes, I'll be there, you know. So thank you. Yeah, thank you for having me. So, you know, my name is Kevin Rosario. I'm the Director of Community Outreach for Gosnell Behavioral Health. If you've been around Cape Cod for a while, we've changed our name from Gosnell on Cape Cod to Gosnell Inc. to Gosnell Behavioral Health. And the reason for that is there's been a shift in our focus, which is very relevant to what you're talking about, Cheryl. So, you know, behavioral health is more all encompassing, where Gosnell, it's actually our 50-year anniversary being in service, and started off as a medical detox in 1972 and evolved into a CSS inpatient rehab. At one point there was a TSS, and you know, we had the Stephen Miller House for the hearing impaired men, alcoholic men very specifically at one point, and then it was like a polysubstance, you know, all addictions type of program. And we had the women's program, the Emerson House, which is a long-term 3 to 6 month program for women, and we had 10 beds for pregnant and postpartum. And you know, times have changed, the landscape has changed, the market has changed, the needs have changed, and so about 6 years ago now, outgoing CEO Ray Tomasi, who was with Gosnell for 42 years, who was the CEO for 26 years, which is really unheard of in this space. People bounce around a lot, your career moves you around a lot, and it's just kind of a testament to, he was pretty dedicated to the Cape and to what he was doing. But he knew there was already, this is 6 years ago, that we were already seeing more co-occurring cases. We were seeing cases of more acute mental health that we really weren't appropriate for. Like if you're familiar with levels of care, like the detox is a 3.7 inpatient medical detox, right? Whereas like AdCare or St. Elizabeth's and some of these other places are 4.0 medical hospital level of care. And then there's inpatient psychiatric, which Cape Cod Hospital has a psychiatric unit. I wish they were here because I don't know the number exactly, but I believe it's 20 beds. And if you think about all of Cape Cod, from Bourne to Provincetown, Nantucket and Martha's Vineyard, there are 20 inpatient psychiatric beds to serve that whole population. And if you ask Cape Cod Healthcare this, and this isn't a poor reflection on them, it is what it is, you know, they have people in boarding, they're boarding every single day, waiting for those psych beds, and not able to get access to them, you know, and Bay Cove has the crisis management contract on Cape Cod, and they will go and do assessments, and they will try to help place at other psychiatric hospitals, because you can go to any psych hospital in the state. And there's a statistic that, don't quote me on this, I mean, it's being recorded, it's fine, do your own due diligence, but it was something to the effect that like 250 people are boarding in hospitals across Massachusetts every single day, waiting for psychiatric beds that are not available. So if you think about all the hospitals across the state, these individuals are presenting at these hospitals at different levels of psychiatric acuity, looking for help, and there's no place to put them. So Ray Tomasi and the board of directors of Gosnell found Richard Kukuru. Richard Kukuru is an LICSW. So he's a social worker, master's level, and has his whole career in psychiatric care. He worked at Metro West. He worked at Cape Cod Hospital with Mike Loft for a period of time. He helped start the dual diagnosis unit at Plymouth High Point, and a variety of other things he's done. But basically, has his whole career in primary mental health. And so the idea was to bring in stronger and more mental health folks to take us to the next 50 years, right? And to really meet the need of what's going on. So within the first year of Richard being at Gosnell, well, within the first few months, he brought in Allie Anderson, who's also an LICSW from the psychiatric space. She's our chief clinical officer. More recently, about a year and some change ago, he brought in Lori Izzo, who's a registered nurse, who's our chief nursing officer, who has her whole career basically in the psychiatric setting, and a whole different, a variety of clinicians for the outpatient world. So five and a half years ago, we started to add mental health primary partial hospitalization program to our outpatient services in Hyannis, in Centerville, more specifically, right in the Lambert's Plaza there at the fork in the road. I think it's like 1158 Falmouth Highway or something like that, Falmouth Road, whatever it is. And so we already saw it, right? There were mental health calls we were getting at the detox. They weren't appropriate for our detox. They were having a hard time getting placed anywhere. And if they're not like actively suicidal and a danger to themselves or others, then a mental health partial hospitalization program can help them get stabilized, right? Because immediate access, we take Mass Health, we take all private insurance, and within 2 days of being enrolled into the partial hospitalization program, you can see a psychiatric provider, which is unheard of. If you're doing your research, you know, if someone calls me, even in my own system, right? If someone calls me right now with Mass Health, it doesn't even matter. You could have private insurance, you could be self-pay, there'll be some more options. But if you call me looking, say, I just want a psych provider, just want to see a psychiatrist. Well, common protocol for all mental health providers or substance use providers is you don't just see the psychiatrist. You have to see a licensed therapist, usually twice, before you can see the prescriber, right? And on average, you're looking at a 4 to 6 week waiting list. And that holds true for Gosnell as well as many other providers. So you got to wait 4 to 6 weeks just to see the therapist before you can see the provider, right? And that's just, people need to get access sooner than that. So it was nice. For the PHP, we got a dual diagnosis track for people with substance use and mental health. And when you get the primary mental health track, both of those are offered virtually as well as in person. So, you know, we have a Falmouth office, but at the Falmouth office, we only do SUD IOP. So it's Monday, Tuesday, Thursday, 9 to 12, but it's for primary substance use. You don't get access to psychiatry and you don't get access to individual therapy. And they chose the Centerville location because it was more centralized to try to give access to more people up in Lower Cape, you know. So that happened already 5 years ago. It's going pretty strong. There's still room on the census. I still have immediate availability. On average, I think today, the Centerville program was only running at like 30, which isn't a lot, you know, and half of them, I think 10 of them were in IOP, so they leave at 12. So it's a manageable census, and we have a huge space. We actually have the space for probably 50 patients per location. We also have a off-Cape site on the Brockton-Stoughton line at the old Goddard Hospital doing the same services. But the patients that are coming in or calling the detox are just a lot more complex these days. It's not the run-of-the-mill 42-year-old high-functioning alcoholic. It's not even the 22-year-old Percocet, OxyContin heroin addict. Like the combination of the fentanyl specifically, the underlying mental health, untreated, undiagnosed, unrecognized trauma, these patients are just more complicated. I wanted to say sick, but it just sounds stigmatizing. But they're really affected, you know. Affected is a nicer word, but they're coming in and they're in tough shape. We've had to extend our medical protocols. We used to be a 4 to 6 day medical detox. Now we're like 7 to 10 because people were leaving AMA on day 3 because they were so sick. Like we had to adjust. We were only Suboxone for opiates, and then we were doing Librium and phenobarbital for benzos and alcohol. And we had to add methadone as a option for for opioid detox because the Suboxone was, not effective for some people. For some people, it was really effective, and it's just been a challenging couple of years. During COVID, when like the world shut down, luckily, we were already doing telehealth. We had this like fancy, Gosnell's always been, I've been with Gosnell, by the way, for 8.5 years. I started off as a recovery coach and an interventionist, and I've been going to school and chipping away at degrees, and I got my associate's degree, and I actually just graduated with my bachelor's degree this spring, and I'm currently enrolled in an MBA in healthcare program at Fitchburg State. I only say that to say, like, I've been here. I'm not just giving you historical information. I've kind of seen some major changes and transitions over my, career at Gosnell in the last 8.5 years. And during Corona, we were already, I lost track of myself. We were already, sorry?
I said, you're doing fine. Yeah.
Okay. We were already, because Gosnell has always been like a kind of forward thinking, the system's broken, how do we improve outcomes? We've always had that kind of as part of our mission statement. And so they had telehealth way before COVID. And so when COVID happened, we just went telehealth on everything, PHP, IOP, the SOAP program, psychiatry, literally, the driver alcohol education programs, anger management programs. So we were in a good position. But what we saw was about a 200% increase in outpatient referrals for primary mental health. Mom, who's now the teacher and the pastor and the caregiver, dad who, has to go to work and work double time because somebody has to stay home or switch the roles, whatever the household looks like. And it wasn't alcohol and it wasn't drugs. It was acute anxiety and severe depression and unmanageability and loss of sleep and stress and all that stuff that came with that. And to be honest, I don't think anybody was ready for it. There's not enough clinicians available to really meet the need. We do the best we can, and we try to serve as many people as we can, but can only do so much, and that leads me to my next point. And part of the problem with finding therapists and psychiatrists and even programs as a whole is there's a national workforce shortage, right? So people went out of work, and some people were getting paid very well, so well that they did not want to come back to work. And also in the middle of that, there was a big boom in treatment centers. So Gosnell, 10 years ago, right before I came to Gosnell, I knew Gosnell. I'm like a New Bedford kid, right? So Gosnell was like, oh my God, like I'm a person in long-term recovery. I've been in recovery since July 2nd, 2010. So I got a little over 12 years myself, and I've been to multiple detoxes, and I could never get into Gosnell. Gosnell was the elite, and in the last 10 years, not even in the last 10 years, in the last 3 years, in New England, primarily Massachusetts and Southern New Hampshire, all within a couple hours of each other, all in striking range. There's now 12 brand new, shiny, fancy, private detox rehabs that do not take Mass Health. And there's this new model, which is unaffectionately referred to as the Florida model, which is basically you get a PHP outpatient license and you have a separate kind of entity, LLC, sober living. And if you have out-of-network PPO insurance, you basically can do PHP, IOP, and they keep you in their housing for 1, 2, 3 months. But they only take private insurance as well. So there's 45 of those there's like 3 on Cape Cod, there's 1 in Plymouth or Plimpton, Kingston, and then there's 1 in Rockland, there's 1 in Hingham, there's 1 in, they're all over the place, Attleboro. There's literally 45 of them, and like 35 of them are in Massachusetts alone, and there's another 10 or 12 of them in Southern New Hampshire. And why I'm saying all this is because with all these new programs, guess what? They need nurses, they need therapists, they need psychiatrists, they need psych NPs, they need doctors. And little not-for-profit places like Gosnell could not compete with what they were paying, right? And so we were forced, after we kept losing recovery aides and nurses and counselors, we were forced, and the government did give some employee retention money, probably like too late, but it helped when it did come. And we had to adjust all of our salaries and hourly wages to try to retain people and try to recruit new talent. And so what that does is, like, there's been times where we've had limited amount of beds available. Not that the beds are not there, but I only have so many nurses. So I have 52 beds at the detox, but today I'm capped at 45 because of staffing ratios. You know, same thing on outpatient, right? I have a huge, beautiful building in Centerville. I have a nice little building in Falmouth. I have an outpatient office in Nantucket. But if I don't have the staff, then I can't see anybody, you know, and that's been a challenge. And if you talk to, you know, I report directly to the CEO of Gosnell. So even though I'm only like a little director, I feel like I have a lot of operational and organizational knowledge because they're pretty open about that, which I appreciate. But if you talk to other like executives and chiefs and all these people at the top, they're all feeling it. You know, they're all feeling it the same, especially like the community-based organizations like Cape Cod Healthcare, Bay Cove, Duffy. Like, they're relying on grants to serve the homeless population. Like, they don't have $125 an hour for a nurse that was just getting $35 an hour. You know, so I'm just throwing all this out there when you're thinking about some of the challenges you have, and some of the gaps. There's a lot of factors involved in all of this stuff. And, you know, hiring and retaining good people has definitely been a challenge across the board. I mean, my father owns a painting company. He can't find painters to paint with him because his competitors are paying $40 an hour and he was paying 25, you know, like, so literally it's unilateral, like across many different sectors. But I don't want to go on and on and on and on and keep you hostage. So I'll move forward to like what's most relevant. So what are we doing right now? So Miller House got sold. Miller House was this beautiful home in Woods Hole. It was sold for $4 million. That is giving us the money we need to do a renovation at Katomet. Katomet was the old fancy 40-bed rehab that was pretty much primarily private insurance and self-pay in Katomet on 28A. That building in Katomet is currently gutted down to studs, being painted, being renovated, and being turned into a 33-bed inpatient psychiatric hospital. And we will be able to serve, we will be licensed. I mean, I probably shouldn't say all this, but the goal, I should say the hope is, even though BSAS and DMH and DPH and everybody that's involved is like, yes, please hurry up, there's clearly a need for it. You got to jump through a lot of hoops, and you got to do square footage, and you got to do a lot of, you know, inspections and all that. But the goal is to have a 33-bed inpatient psych hospital that will serve 16 plus. So yes, the adolescents, it's not just on Cape Cod. The adolescents nationally are an underserved population. So are the elderly population, underserved population. And it's twofold. One part is they are high risk and harder to manage. The other part is sometimes the programs are hard to sustain. Like, you know, you need them, but the kids typically are in school until 2:30. So then you can't have day programs. So then your evening program, or you have a pocket of kids that are out of school because they're acute. And it's like hard to get the numbers you need to have a financially solvent program, even though everyone knows we need it. That's been a challenge. So we're trying to help meet that need by going 16 plus, getting the older adolescents, even though we know that as young as 12, they're going to need some help. And the goal would be, once the psych hospital is done, it would have been January 1st, by the way, but because of supply chain issues, we need a hospital grade HVAC system that's apparently only produced in Mexico, and it's 6-month back order. So we're shooting for June of next year. So hoping for June of next year to have this hospital online. And with that, we are already looking at how can we create more services for the adolescents, because there are none, right? So there's a building not far from where Katomet is that they were looking at already, and the goal would be to be able to do adolescent, have an adolescent outpatient office. So PHP mental health, PHP dual diagnosis, IOP half days, you know, evenings, excuse me, for kids that are actually still able to stay in school. And what's nice about the psych hospital, which is definitely happening, and I can only hope the senior team is trying, you know, sometimes just can't find a building, you know, it's like there's limited space and limited buildings. But what's nice about this world is it's kind of payer blind. We'll take Medicaid, Mass Health, and we're going to take Medicare. And what's nice about the psych space, and you may have heard this if you do any kind of lobbying, not lobbying, but advocating about mental health parity and SUD parity. Inpatient detox for Mass Health, the reimbursement does not cover the cost to actually detox someone. It just doesn't, right? So you got to raise money and get grants, and you need a certain amount of self-pay and private insurance to make it work. On inpatient psychiatric, even Medicare, which is typically the lower payer, well, Medicaid and Medicare, sometimes Medicare pays better than some of the Medicaids, but even the Medicaid and Medicare cover the cost of treating a patient. So that takes a lot of stress off of the system of Gosnell, and you can just focus on treating whoever is presented to you. It's not about money. It's not about insurance. It's obviously a huge need for the Cape, but it's also a good service line for Gosnell, honestly, so that we can continue to do the great things that we do. Like everybody knows we got the detox. Some people know we have a couple of the outpatient offices. But what people don't know is we have like 8 coaches in 5 different hospitals doing interventions for free and placing those people in other treatment centers often because we don't have a bed. We have 5 free family support groups. We have a Gosnell clinician working in 60 schools on and off Cape Cod, all the way up to Braintree and Stoughton through Plymouth, all the way up and down Cape Cod. And we don't charge families for that service, right? Community partnership, recovery coaches, I can go on and on about all these ancillary services that don't really get any shine, that most of them lose money. Some of them fight to break even. So as an organization, you got to find ways to make sure that you can make payroll, right? And that you can continue to support these other very important, programs. So that's really exciting. You know, I'm excited about it. I wish there wasn't a supply chain issue because it would happen a lot sooner, but it is happening. We will have the psych hospital. We will eventually find a way to do some more outpatient services for adolescents. I will say that with the school-based counselors that are in all the different schools on and off Cape Cod, they do work with young people and their families. So just like anything else, sometimes there's a wait list to get them to be seen, but we are hiring and trying to get to the place where we have more school-based counselors that can see young people quicker and give them some support. I feel like I've said a lot, and I want to pause for a second. Is that hitting on some of the things that you were hoping for, Cheryl? Are there gaps?
Yeah.
Are there questions?
Yes, we are tasked with trying to identify the community, some of the main community needs, and to try to put together some suggestions to put forward to the town council. So what I'm trying to do is to get key speakers in over the first 4 meetings to try to figure out. So we're going to with an educated background in it. Addictions is one of the things that has come up repeatedly, along with mental health, and the two go hand in hand, as you and I both know. We also had the executive director from Cape Cod Healthcare on the first meeting. They are talking about doing a teen center. I don't know if you ever thought of teaming up, but it sounds like you do a lot of, you're talking pretty much about the same type of things, and maybe working in unison would work. And I can't speak for them, but that was something I would be considering. Especially since when we first spoke, you said that's the teen thing is just not enough to address it on the Cape, and we know that that's an escalating, particularly with fentanyl and that kind of thing. It's just skyrocketing out of control. Yeah. And Gosnell is a fabulous organization that has done. I shudder to think where we would be if we didn't have Gosnell and other similar facilities. I'd like to open it up to the committee members. Carlos, you're the only committee member who is here. Do you have any questions? And then I am going to ask Kim, because it looks like she will soon be a committee member, but as a member of the public, I will invite her to talk. Please, Carlos.
Well, actually, I have some comment. I have some questions too. My comments 15 years ago, I had an employee in Nantucket work as a painter. He was drinking like crazy, and thank God for Ray Tomasi that accepted my phone call and helped the guy. The guy was there for 2 weeks with you guys, and from that point on, he never touched a drink again. So I'm so happy, and he's still working for us over there in Nantucket. So
That's great.
a nice story. Ray Thomas is my hero, so I'm glad I hope he's okay wherever he is. So
Yeah.
the other thing too is not too many dollars out there and grants. So like Cheryl says, team up with Cape Cod Hospital is not the idea to fight for the same dollar, or
So that would be beyond me. I'd be honest with you. Like, I know my CEO and Mike Loft talk a lot, and so they could be communicating. I haven't heard of it yet. You know, I know we work very well with them. We have 2 recovery coaches in Falmouth Hospital and 2 recovery coaches in Cape Cod Hospital in Hyannis. So we already help. And I literally got a referral today from their psych center where someone is being cleared psychiatrically but has co-occurring substance use issues. And the girl's going to come to our CSS rehab. So there's a lot of relationship stuff there. I don't know about the partnership. I have heard about the teen center thing. And so my takeaway will be, I'll bring it back to Richard Kukuru and just ask, hey, what's going on? Are we involved in this? Should we be? Can we be? And let the chiefs see if they can work something out.
And I have to stress, I'm not talking on behalf of Cape Cod Healthcare. It's just, even though I am an employee of Cape Cod Healthcare, but it is something that they presented to us at the first meeting in June as something they wanted to do. And that's part of our job to try, where can we make some connections here? And trying to bind. Carlos, did you have any more questions or comments?
Just regard to the non-speak English people. So how we deal with that on the Gosnell right now? So
yeah, so I'm sorry I forgot about that, and I'm so glad you asked. So, as you know, another grossly underserved population, all peoples of any other language, there's no way you can go. It's like really hard. So what we actually just did, and we haven't piloted it in outpatient yet, because I get calls for Spanish speaking IOP, and there is no Spanish speaking IOP. When you go up north, Springfield, you got Gandara, you got Casa Esperanza, and there's the other programs that definitely do a better job with that population. But on the Cape, there's not much for Portuguese, Spanish, and Cape Verdean. So what we did, it's funny because, not funny, but we hired a gentleman who's from Jordan, and his name is Dr. Ahmad Al Musa. And so he's the senior director of quality and compliance, and he works really closely with BSAS, and not just making sure you just check stupid boxes to keep your license, but to actually see if we're meeting the needs. And one of the things that came up, I told him, I was like, hey, Ahmad, like, he started doing the Gosnell handbook in literally Arabic, Spanish, Chinese. I'm like, hey, listen, God bless you, bro, but like, we can't serve those folks right now. When they call me, what do you want me to do? Like, you're setting me up. We got to figure out a way. If we're going to advertise, like, it's great. Oh, you can read our literature online, that it's accessible for them to read, but they can't actually participate in the services. So we found, and I give him credit for this, he found a translator device. So he bought, Gosnell bought 4 translator devices that are 2-way. And one is an ear pod and one is a microphone. And like, you could wear one and I could wear one, and I could be talking to you in English and you hear it in Spanish, and you can talk to me in Spanish and I hear it in English. So a patient can now currently, as we speak, go into my detox and sit in group therapy and completely understand everything the facilitator and all the other patients are saying. And at least he can communicate, or she can communicate back to the facilitator, who will have the other receiver. And then he or she could say, hey, Carlos said, blah, 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 that's his feedback. Because we're not going to buy him for all 50 patients, but.
And Kevin, I just want to let you know, that's great you have tools like that, but feelings sometimes cannot be translated. So as opposed to somebody else who speak their own language, know the feelings when they say something to them. And I want to you, we have an organization here in Hyannis called Health Ministry, run by Michael Messinas.
Health Ministry?
Health Ministry, yes.
Okay.
You can find that on our website. So Michael Messinas speaks 5 languages: English, Portuguese, Spanish, Creole, and Italian.
Oh, wow,
so,
I love that.
And we've been teaching people how to speak English and all that, but get in touch, because it could be a great connection to have a translation being done by them to you guys. So
what are you saying? Will he come into the facility?
Well, I don't know. Depends. We have so many people who speak English, Portuguese, and Spanish there, so be able to help you out somehow.
Because BSAS says, oh yeah, if you have Spanish or hearing impaired, we'll accommodate. But here's the problem. You put in a request with BSAS and you're on a waiting list for an interpreter. And then they say, oh, we'll give you an interpreter, but we can only give you an interpreter 3 hours on Monday, Wednesday, Friday. Well, what about on Tuesday? If the guy's having heart palpitations, he needs to be able to express to someone. It's been hard, and at least,
Yeah.
I hear you, Carlos, and I wrote that down, Health Ministries, Michael Messina, and I'll pass that along. But at least it's a step in the right direction, because you know what's happening? Admissions was kind of like dancing around it, because technically you can't say no, but we couldn't really safely help them. So they were kind of getting the runaround at times, I think. And at least now we're like, yes, at least they can come in, and if they don't feel good, they can go up to a nurse, and a nurse can have another piece.
Right.
It's at least a step in the right direction. It's not the solution, but I want, and if Health Ministries, Michael Messina, and if you could share maybe your email address with me, or you can get my email address from Cheryl later, we could talk more about this. I'm Portuguese. I don't speak fluent, but my father came here when he was 19 years old. I grew up in New Bedford. Most of my friends is Portuguese, Spanish, and Creole. And they're mostly first generation. Their parents don't even speak English. They speak broken English at best, So I personally would be invested in trying to help move that along. It's just been challenging,
Carlos, do I have your permission to pass on your email address to Kevin?
Please, yes. And I'll
I never
send.
do it without permission. So
Thank you.
Thank you, Carlos.
I will
Thank you.
send that to you. So, yes, thank you, Carlos. I'm going to open it up for public comment, and I'm sorry, Kim, until you have your second reading, that's the only place I can put you. But we're looking forward really to welcome you on as a full member of the committee. Be interested to hear your comments on it.
Oh, thank you. Can you hear me?
We can hear you. We
Okay,
can't
well,
see you, but we can hear you.
So, thank you, Kevin, for that really informative presentation. So I'm a medication prescriber here at Cape Cod Human Services, Cape Cod Healthcare. So we're right down the street from you. I was fortunate that my first interaction with your organization was through Justin Campbell.
Yeah,
That
was my guy. I trained him. I brought him out of the hospital as a recovery coach. And, I feel like he's like my little son, my little brother. Like he's a Gosnell alum. He started off as an RS. He started doing interventions in Cape Cod hospitals. And then I took him out to do community outreach and business development. And he just took off. He was starting to work for this national company in Haverhill. And now he's working for New England Medical Group, which is an outpatient provider in Hingham. He's got a VP of business development job now. He's probably doing much better than me.
But he also was somebody who, when it came down to it, and it was a Saturday, and I had no one else to call, he would move a mountain to, and I have the utmost of respect for your organization. And you are correct. The CCH inpatient unit has 20 beds. And, I can just relate a recent story of, a patient that I sent from my office who was in acute mania, who also had a substance issue. And, she spent 6 days in the CCH ER. And, there's this awful adage about if you hang out in the ER long enough, you'll get fixed and you'll get to be dismissed. And that's what happened. And, there's such a void there. And, I wish there was a more formal way that we could interface with like what you have available, like actually with some of your folks, because I know that when I call over sometimes, because I want to do a referral, I can't actually get a real person on the phone, or I can't get a door to open for me. Like it used to be Justin I would call. And now I'm kind of like, all right, what do I do? And
great news. Great news. You just met Kevin Rosario. So you got a guy now.
Well,
so I'm 100% that guy.
Share your contact. That would be great. But I'm also, wondering if we can be of benefit to you by referring some of these folks, because the conundrum we run into here, up on 460 West Main is if they have a substance abuse issue, a lot of the feeling here is we can't properly treat them because we don't do Vivitrol. We don't do, we do things that are by mouth, but not injectable. And so then our recourse is, send them to Gosnell or send them to Duffy. And I wish we could keep some of these folks, because why get them reestablished somewhere else where it's taken them years to get established with us,
Right.
That makes me sad. The other, I'm just asking you this out of curiosity, because this is concerning me a little bit. I won't name the name of the place, but I understand there's a place in Hyannis that has recently opened that is sort of kind of freely giving out advice and also meds like Suboxone and Methadone. And I had this just occur with one of my longstanding patients who doesn't navigate very well. And he tends to fall off the wagon quite a lot with alcohol. So he also recently used cocaine. And that was a very out of character thing for him to do. So he saw that this quote place was available. He walked in and they gave him a telehealth visit for like 20 minutes and then decided to give him a script for like Suboxone. And that's not what I want to see either. Do you know?
Yep.
But my concern here is this particular organization seems to have a lot of availability.
Right.
But I want to have credibility with availability. And I think you guys offer that so well.
Right. Thank you. So again, the sad reality is that mental health and substance use has become a multi-billion-dollar industry.
Well, I was just going to say that it's an industry. Yes.
And Florida got overregulated and a bunch of people got indicted and a lot of places got shut down and they moved north. And many of these new for-profit conglomerates are private equity. They have people behind them that have money that want return on investment and do not come from SUD. They're construction people, they're investment people, they're property people, and that's a sad reality. And I don't care. I will say the names. There's Column Health, and they're being bought out by Brightview. So Column just started out on Hyannis.
That's the one.
Yeah. So you got Column, and you got Shane Catino running around. I like Shane. He's a local guy. He's trying to help, and.
I am going to interrupt. We want to be
sure.
careful about naming names because this is recorded, and
Okay.
I just want to protect people, so we want to kind of be careful.
Well,
on
I'm more concerned about just the general. How do we steer clear of that? While I want caution for these kind of situations. Right. And so I'd love to know how we could interface with you more and your organization more directly. I'm sure COVID made it difficult for us to do that too. Yeah. And so, now that I've heard your presentation tonight, I have much more hope about being able to refer folks your way.
Yeah, I think we can do something. And Cheryl, I want to finish my thought. Like, I wasn't even going to trash Shane or Colin because I'm friendly with them. What I've done with them is because their niche is instant access to Suboxone. And what they feel was, like what you guys are doing, you're trying to eliminate barriers and people are having a trouble getting access. So they got all these programs popping up. There's another one called Recovery Connections, and there's another one called Better Life Partners, and they're popping up all over Massachusetts. And they're really primarily doing Suboxone, Sublocade. Some of them are doing Vivitrol. And like the bare minimum requirement is like a 20-minute telehealth eval and then weekly like 20-minute check-ins. So what I've done, because as a professional and a person in recovery, I know that's not enough, right? So I'm not knocking that model. That can help someone not die of an overdose. I'm okay with that. But I've actually been working with Column and Recover and all these other programs and say, look, you guys are doing prescribing. That's great. Let us help you. Let us do the PHP. Let us do the IOP. Let us do more heavy comprehensive clinical work to support your patient while you do the medication management. That way the patient can have a better outcome. So I feel like some of these places that are popping up have good intentions, but they definitely are not it's not comprehensive enough for the complexity that we're dealing with. So I just wanted to finish that train of thought on that whole thing. I wasn't meaning to sound like I was being negative.
And what might, I'll discuss it. Right now, it's a meeting for human services, but it might be an idea, because Kim brought up some very pertinent things, is maybe have you, we could suggest that you present to some of the practitioners. Because
Yeah,
then
and-
work out a plan.
And I can tell you this right now. I'm available, right? So Kimberly, I don't know exactly what you need or what you want, but like, I'll go see you. We can grab lunch. We can have a private Zoom. You can tell me what your needs are and I'll do my best. One thing I am is I'm 100% real, sometimes too real. People don't know how to deal with me, right? You call me and you say, look, I got this girl that's got mass health and this is what she needs. Can you help? Do you have a bed or not? I'll say, hold on, please. Director of admissions. I got a referral. Do we have a bed or not? No, I don't have a bed today. I could probably get her in 2 or 3 days. Okay, great. And I'll let you know. We're not going to do the runaround and the phone call and the intake and the mythical waiting list. Like, you know, inpatient detox and CSS is a lot harder to get access to because there's just more traffic there. Outpatient, it's always yes. PHP, IOP, you can start the next day. And by the way, one thing that I feel like Gosnell does that other places don't do is we made a point to say, if you participate in our PHP or IOP, you do not have to drop your therapist or your psychiatrist or any other of your team members that you may have been working with for 5, 10, 20 years. You come in, you sign a release, we work together, you do a month or 2 months of PHP, IOP, you go back to your provider, you go back to your primary care doctor. Most people that prescribe say, oh, you have to be our patient, and they want to completely hijack the patient. To your point, Kim, you got someone that's got a 5, 10, 20-year history, but they just need a little bit more, and you hate to see them go and never come back. If that's the plan from the beginning, they can do the group therapy with us, stay with you, and go back to you when they're done.
We're going to be talking more on that. But Cynthia, can I just ask you, do we have a hard stop at 6:30?
No, Madam Chair, you do not.
Okay, we won't be going much over. I just want to make sure we're not on the minute. Kevin, I think what you've had to say is extremely pertinent. It's very informative. Carlos, Kim, do either of you have other questions, or?
I just want to let, he's going to hear from me soon, I hope, you know, and I'll do anything I can to help you all make that connection between language and your organization, okay?
Thank you so much. I appreciate it.
So do you have anything more, Kevin, you wanted to say?
I just will say one last thing, and I want to say it as Kevin Rosario and not record it as like the Gosnell statement, but just as a person in recovery, what I see on a daily basis, if you ask me what we need the most, I got people being discharged from the detox every day that can't make it to another level of care, and they have no place to go, and they can't even find sober living, and if they do, they don't have funding for it. So my biggest challenge on a daily basis is someone that comes into detox and has nowhere to go. I don't have the immediate solution for that, but I can tell you that recently, a gentleman who's a Gosnell alum who owned the best sober houses on Cape Cod, if you ask me, got into the PHP outpatient business and started using his houses for housing for his PHP, which is fine. God bless him. He's doing well. I'm happy for him. I know him and his family. But what that did was it took like 4 or 5 of the best houses off Cape Cod, specifically out of Falmouth and out of Mashpee. So there was some less desirable sober houses that were like anything goes, and we won't even refer to them. So that's a challenge that I see as a person in recovery and as a person who sees what goes on. You have people that want further treatment, and we can't get them to another program, a CSS or a TSS. And we work with like Moms Do Care, and there's a couple other random organizations, the Heron Project. We work with Magnolia. We work with Family First. There's like a bunch of small organizations that will say, hey, we'll give you $300 for move-in fees for sober living. But I can tell you on a daily basis, someone gets discharged to Falmouth Hospital, to Walmart, because there's nowhere for them to go. And that sucks. That really hurts. So I don't propose to have a solution for it, but just to throw that out there, you know, there are people that don't have their basic needs. They don't have food. They don't have a place to live. And there's no chance they're going to stay in recovery if they don't have that.
Right.
I agree. Can I ask you, Kevin, do you have numbers, statistics?
What kind of
Just
numbers?
just for Cape Cod?
What kind of statistics?
Roughly how many people maybe that Gosnell treats per year? Also, what proportion are teens? You mentioned that this one would be for 16 plus, but yeah, we do know that there are some that are 10 and 12 coming, but and presumably if they are 10 or 12, there would be some sort of help for them too.
Yeah, so unfortunately for us on Cape Cod specifically in Falmouth and Hyannis, I think I have 2 licensed adolescent therapists that have extreme wait lists. So I have a couple people that can serve 12, 13, 14. Believe it or not, I get calls for 9-year-olds that are looking for individual therapy. And I don't even have a person that specializes in that. So we don't currently serve a lot of teens. Now, so the answer is yes, I don't have it in front of me. But Amado Al-Musa, who is a statistic guru, we did recently, because it's our 50th anniversary for the gala, we presented to the board that, basically in the last 5 years, Gosnell has served 10,000 people. And we have those numbers by town because we were trying to figure out how much of our business is on Cape and off Cape. And it was about 50-50. But so there is a PowerPoint somewhere, assuming he'd be willing to share it. I could tell you like how many Cape residents have received services from Gosnell in the last, 5 years. And it could probably be broken out by age and everything. So yeah, I could probably put something together for you or connect you with Ahmad who could do it.
If you could, yes, please, when you have a chance. I mean, I have a goal that I would like for the committee to try to put something preliminary together to present to the town council before the end of the year. And as I said, we're trying to hit as many of the key areas as we can. Next time I'll have some people from housing and hopefully youth coming on. But I would like to present as strong a case as possible and with the other committee members agreeing. Cynthia, can I just ask you, and I might have asked you before, is there any problem with us having a regular youth, not so much a seat per chair and a vote, but because they're not adult yet, but input on the committee?
No, there's no stipulation at all. If you wanted a representative from the youth commission,
Okay.
you could definitely do that.
Okay, or students if they wanted to, because we did have those 3 students that wanted to present to us, but they never responded back. So
I just had a random thought, and I'm going to throw this out there to you guys.
sure.
I'm an off-Cape guy. I've been at Gosnell for 8 years. I've done my best to make connections, but I think what would be super helpful if you would be willing to organize at the end of all of these different people you're talking to, and you get an action plan and you identify top 5 issues, it would be super helpful to do a networking event with the players. I don't know the people at Hack. I know Heidi Nilsson at Duffy, but like I don't know the people even at Cape Cod Hospital. Like all the people, like whoever it is, sober living, clinical, medical, psychiatric, like get the biggest players on Cape Cod and get them in the room so we can tell each other what we do and how we can help each other. Because I feel like some people are overlapping and there's gaps where the service exists, but we don't even know it exists. So just that would be helpful for me, and I think the people we serve.
We think alike. It's part of the game plan.
Good.
So can people hear me all right? Because I'm getting some feedback. It sounds like I'm growling at people. Is that okay? Okay.
You're
Not
fine.
growling, I promise. Okay. Any other comments? And you will be hearing from me if you can get the numbers. I'm going to go on. There are no other items not reasonably anticipated by the chair. We've had the guest speaker. I wanted to have a chance to actually talk tonight with the committee and to try to start putting together this plan because it doesn't seem fair because we are missing 3. So I'm going to put that as a key on the next agenda if nobody objects. And I'll probably send something out. Carlos, you said you received that list. The others did as well, I'm sure. I'll try to put together some sort of proposal and for people to consider. You know, as I've said before, I might be chair, but I'm only one vote, one voice.
Right. I just want to let you know that I'm kind of disappointed of this committee because too many people don't give the importance of this committee. You know, people are busy. They're at the end of the summer, but it's your responsibility to show up for those meetings. So I do my best to do everything I can, but you know, I understand people are busy, but they have to show up. Okay. That's my protest here.
Okay, fair comment. So anyway, I do not believe we have anything else. Kim, I don't want you to feel forgotten. Anything else real quick? Nope. All right. In that case, we can't really take a vote. I'm going to go ahead and continue the minutes to the next meeting for that agenda because we don't have a quorum for voting on approving the minutes. And I don't think I can take a motion to adjournment, but I think as chair, I can go ahead and say to adjourn on the basis that we are at the end of the meeting if there's no objection. Carlos, you look like you're about to say something.
Hey, thank you to Kevin. Thank you very much for your presentation.
Yeah, Kevin, thank
That
you
was
so much.
wonderful.
Cynthia,
Wonderful.
any problems with me? We don't
And
need.
I think, Cheryl, you and I can follow up with our colleagues here about what we just heard and respond back to Kevin. I think this was so helpful.
Yeah. You'll be hearing from us, both Human Services and other. I think, Carlos, you have a thing for people to kind of get together, and it is already in the game plan to identify some of the key players. It's not going to be all of them, but we have to start somewhere.
Absolutely.
And you know, to keep that ball rolling.
And it's not always the chiefs, by the way. Like I've made the mistake in the past of getting a bunch of chiefs in a room, and God bless them, they're not on the ground. You want the directors and the clinicians, the people that are in the offices, because sometimes my chief, and I love him, he'll say, do this. But it doesn't always happen. You know what I'm saying?
Right.
We got 450 employees in the company, you know, so, but you go get like Martha Jackstimer, who's in the detox 50 hours a week, and you try to she's getting it done. She's there, you know, like, so get the people, not necessarily the decision makers, but the worker bees, you know, get the blessing of the chain of command, but we also want the people that are on the ground.
You got it.
Do I need to ask for a motion to adjourn, or do I just adjourn it since we do not have a quorum?
No, Madam Chair, you just adjourned.
Okay, so sorry, Kim, was you about to say something?
No, I just said I love that you have this much power, Cheryl.
To adjourn, I mean, oh my goodness. Kevin,
And you're following Robert's rules so nicely. I applaud you.
it keeps everybody safe. Kevin,
Yes, I know.
thank you so much. I think
My
we
pleasure.
made a lot of headway here. And I am going to go ahead as chair and to adjourn the meeting. Thank you very much. And
Perfect.
you are also welcome to attend any of our future meetings for input. Carlos, Kim, Cynthia, have a fantastic evening.
You
You
too.
also.
Thanks for the good work.
Thank you,
Peace out.
Kevin. Bye,
God bless,
Carlos.
guys.
Bye, Cheryl.
Bye.
See you tomorrow.
See you
Bye.
tomorrow.
Thank you, Cynthia.